Hi everyone, thanks for listening to my presentations. Today I'll be talking about multi-drug resistant tuberculosis. Multi-drug resistant tuberculosis. Okay, let's go. Drug resistant TB is a very difficult situation to handle. We can use the second line drugs. Surgery may be necessary. If you are not directly dealing with an expert or this is not being handled directly by experts in TB, then we must be in contact with an expert in multi-drug TB treatment. The resistance could be to just one drug, but sometimes could be to more than one anti-TB drugs. Types. It could be monoresistant, and that is to only one drug. Polyresistant TB would be resistant to many drugs, and that combination will either include INH or rifampin, but not both INH and rifampin at the same time, no. But if we are dealing with multi-drug resistant TB, the resistance will be to both INH and rifampin in addition to some other drugs. If it is pre-MDR-TB, which means pre-extensively drug-resistant TB, then it will be resistant to INH, rifampin, and either quinolones or all injectables like streptomycin, amikacin, kanamycin, or capromycin. If it is SDR-TB or extensively drug-resistant TB, it will be resistant to INH, rifampin, fluoroquinolones, amikacin or kanamycin, or both of them, that is the both aminoglycosides, including capromycin. TDR or totally drug-resistant TB will have an isolate of Mycobacterium tuberculosis that is resistant to all locally tested medications. That's a big problem. But the definition above may not include the less frequently used drugs against TB. For example, cyclomerase, linezolid, chlorvasamine, terazidone, carbapenems, and bedaquiline will not be on the list, which means you can still use this. Secondary or primary drug resistance. Sometimes an individual could be susceptible to anti-tuberculous drugs, but later becomes resistant, and we tag that secondary drug resistance. It is possible to be infected with a drug-resistant strain from the onset, and that is primary drug resistance. The first-line drugs, if you check my page on treatment of TB, you're going to get the list of first-line drugs: INH, that is isoniazid, rifampin, pyrazinamide, ethambutol, and you're going to top it with pyridoxine to suppress the neuropathy of the INH. And the second line drugs, fluoroquinolones, aminoglycoside, and the rest of them, you are going to get that from the treatment of TB on my channel. Check that out. What are the clinical features of the situations or scenarios where we're going to find multi-drug resistant tuberculosis? It is similar to non-drug resistant strains. Okay? but you are going to have some additional info that will give you a clue. In case of multi-drug resistant tuberculosis, we're going to have the history of previous TB treatment. That is in case of secondary resistance, right? Somebody is asking me, but we just said primary resistance. Of course, by the time we come, don't worry, progressively worsening conditions. You've seen it. You've tried to do everything, but the condition is not improving. Radiological evidences will persist. You have serial chest x-rays or CT taken, yet no difference. Or the person resides in regions already known, marked, identified to have multi-drug resistant tuberculosis. Or the person has just traveled to and has just returned from a region known, identified to be having multi-drug resistant tuberculosis. Or this person has been exposed to a patient with multi-drug resistance. You could now see that from what I have said, the last three lines, they are pointing to possibility of primary drug resistance. Okay, the person acquired the strain of Mycobacterium tuberculosis that is already resistant to TB drugs, either because the person is living in that zone or travels there or has been exposed to someone having that strain. Be suspicious. I'm not saying you should be suspicious of your nurses, of your patient, of your family member. No. Be suspicious of a drug-resistant strain of Mycobacterium tuberculosis if the person is on TB drugs for 3 months and the cultures are not negative for Mycobacterium tuberculosis, then be suspicious. Be suspicious if there is any sudden relapse without any evidence of any cause of immune suppression. It's not that this person has been treated, okay, discharged by you, has gone home, and there's no history of new DM diagnosed, no HIV, not on chemotherapy, not taking tissue necrotic factor alpha inhibitors, not on disease-modifying anti-rheumatic drugs, and not on radiotherapy. This person has just had a relapse. Be suspicious. Be suspicious if this is an immigrant with TB and has just returned from a multi-drug resistant TB regions of the world. Be suspicious of primary drug resistant TB in him or her. That's what you call empirical treatment. Empirical just means you have not made a definitive diagnosis based on laboratory, but because of your clinical acumen, which is very high, you want to embark on treatment pending the time that you have all results of investigations to make definitive treatment. So empirical treatment. It is better to have a culture-based drug susceptibility done. But because we don't have the luxury of the time to wait, we have to start something. That is empirical. Once clinical features and the degree of suspicion is pointing to multi-drug resistancy, then we have to start. Empirically, we can start using first-line drugs with second-line drugs, okay? Because we don't know how many of them this individual is susceptible to or resistant to. So we just choose first line, second line, and start. You are going to add more medications if there is miliary tuberculosis or TB meningitis. And of course, we have to trace the contact or contacts. That will enable us to know what has happened. For example, somebody has just traveled to a particular region and return, and he or she has developed primary resistant tuberculosis, then if we contact the region and the public health officials will reveal to us that, oh, we have this strain here. All TB cases here are resistant to INH, but they are not resistant to rifampin, or they are resistant to both INH and rifampin. Then you have the clue that you are not going to use those drugs that they have mentioned on the list. You use others. And that will determine the susceptibility and, of course, your sources. Now, if you're confused, contact the TB experts. Adjust your treatment, adjust your empirical treatment after susceptibility results are out. If monoresistance, then increase the duration of treatment by 3 months in HIV positive patients. If resistant to INH, you can use rifampin, ethambutol, pyrazinamide, levofloxacin for 6 months, but up to 9 months if HIV positive. You can decrease the duration of the pyrazinamide to 2 months. You can use rifampin, ethambutol, and fluoroquinolones for 9 to 12 months. If still monoresistant and in a region with INH resistant greater than 7%, and you can test the susceptibility to INH today, then close your eyes and give INH, rifampin, pyrazinamide, and ethambutol for 2 months, then INH, rifampin, and ethambutol instead of INH and rifampin for the next 4 to 7 months. You can pause to go over this. Check my channel for the video on TB treatment. That will give a better clue. If monoresistant to rifampin, though that is very rare, but you're going to treat like multi-drug resistant tuberculosis. If monoresistant to pyrazinamide, please use INH and rifampin for 9 months. If it is ethambutol monoresistancy, you can use INH, rifampin, pyrazinamide, pyridoxine for 2 months, then INH and rifampin for the next 4 months. If 2 or more drugs resistant, like INH and ethambutol resistancy, you can use rifampin, pyrazinamide, levofloxacin, or moxifloxacin for 6 to 9 months. If it is INH and pyrazinamide resistancy, you can use rifampin, ethambutol, levofloxacin, or moxifloxacin for 6 to 9 months. INH, ethambutol, and pyrazinamide resistancy will force you to use rifampin, levofloxacin, linezolid with bedaquiline for 9 to 12 months. If it is multi-drug resistant tuberculosis, this refers to mycobacterium tuberculosis that is resistant to INH and rifampin, or rifampin monoresistant. You are going to follow DST results, which means you are going to follow drug susceptibility test results. You have to find out prior anti-TB drugs history and adverse effects and toxicity, availability of the new medication and the cost. And you can use 5 or more drugs that the isolate is susceptible to based on DST, that is based on drug susceptibility test. And of course, contact the TB experts in your jurisdiction. Multi-drug resistant TB treatment. You can use bedaquiline, linezolid, levofloxacin, clovarsimine, cyclomerase, or terizidone. You can use either amikacin or streptomycin. Don't use both, just one. Other drugs that you can choose from are delamanid, pyrazinamide, ethambutol, etunimide or protonamide, imipenem, cilastatin, clavulanate, meropenem, clavulanate, p-aminosalicylic acid, high-dose INH. Note: treatment of multi-drug resistant TB is up to 18 months. You are going to treat drug-resistant cases for a long period of time if multi-drug resistant TB is in certain cases, like miliary tuberculosis, CNS involvement, given hydrocephalus or TB meningitis. It has associated HIV co-infection, you treat for a longer time. If you are dealing with extrapulmonary tuberculosis, like I've said, TB meningitis, or this is a pregnant woman, or patient prefers that, patient's preference, you can treat for a longer period of time. You are going to treat for a shorter period of time if multi-drug resistant TB are not having the cases that I've just mentioned in the previous slide. You can use INH, pyrazinamide, ethambutol, clovarsimine, moxifloxacin, kanamycin, and protonamide. But you have to do that using the readily observed therapy throughout. What are the indications for surgery? Somebody is saying, oh, he's talking about surgery and we're talking about TB. What is the correlation? Chill. Okay. You embark on surgery if you are getting poor clinical outcome and you are sure this is pulmonary tuberculosis and you are sure this is localized to a lobe. And of course, you've taken your sputum cultures for 3 to 6 months. The individual is on anti-TB drugs, yet they're still positive. You have given extensive medications and there's extensive drug resistance. There's hemoptysis, but this time around is very massive. You don't want the patient to die of hypothalamic shock. Or you are finding bronchopleural fistula, then you are back on surgery. The surgery must be limited to one lobe, lobectomy or wedge resection. The surgeon must be sure of adequate pulmonary reserve. Even with the best surgeon and successful surgery, you still administer your full drugs for 6 to 9 months post-surgery. The last slide. No more surgery, because I will end it with no more story as per TB. But before you ask me, let me answer. No more surgery, why? When you are dealing with extrapulmonary tuberculosis or miliary tuberculosis, you are not going to go and look for all the organs involved and start cutting them off. No. It's like any cancer that has metastasized. This is TB metastasis, if I'm permitted to give that nomenclature. So you don't look for regions where they've gone to. Just give up. Even if it turns out to be multi-drug resistance or not, we can do nothing when it has gone far, like MDR-TB, like TB meningitis, Port disease, TB affecting the kidney, and TB pericarditis affecting everywhere, even TB orchitis. Is bad. And with this, I've come to the end of all presentations as far as tuberculosis is concerned. And I believe very strongly that if you can go over all the presentations on TB, you'll be well informed as far as tuberculosis. Other things you need is talk to your doctor, or if you're a doctor, contact an expert. Thanks for listening. Kindly remember to subscribe, share, and forward to your friends. My heart goes out to all affected TB patients, millions of them worldwide, and wishing all of them a quick relief and speedy recovery. Cooperate with your physicians, take your medications, and be fine. Thank you. I appreciate it.